Hello, welcome back to Oral Surgery Board Review. This is my fourth installment. We're going to be talking today about TMJ procedures. So this is the second video on TMJ. In the first video, we talked all about the anatomy and pathophysiology, and you should check that out if you haven't already watched it before watching this one. And this is going to be kind of a continuing on, and there will be a little bit of overlap, but for the most part, we'll be talking about all the different various TMJ procedures that exist. And two little quick caveats I want to mention. The first is that this is not intended as a how-to instructional video. As a plug, I do have that on my channel and you can check it out, but this is intended from a board vantage point specifically. What are the procedures and what kind of questions that you may get asked regarding these procedures? And the second thing I want to point out is the boards tend to be a little bit dated. So everything's like 10 or 20 years old, and some of what I'm saying may not be relevant to today, but it's really important for you to know from a more historical standpoint. All right. And as an outline, let's just run through all the procedures we're going to talk about. So first we're going to talk about arthrocentesis. Then we're going to be talking about a high condylectomy, and then a condylotomy, and those are not the same thing. Those are two separate things. And then we're going to be talking about arthroplasty, and within that category of arthroplasty, you have various procedures like Eminectomy, Discopexy, which means to suture the disc, and Discectomy, which means to remove the disc. And then finally, those are everything up until that point would be like minimally invasive. If all else has failed, then you're looking at TJR, which is total joint reconstruction. And within total joint reconstruction, you have various approaches, including Autogenous, along with distraction osteogenesis, and finally Alloplastic, which is probably the workhorse of modern day TMJ procedures. But like I said, we're going to be going through all these one at a time. So let's start off with arthrocentesis. That means to irrigate, wash out, lavage the joint. And the solution that's used is lactated ringers, and that's because that's most physiologically similar to joint fluid. And studies have shown what's the necessary volume for lavage. So 100 cc's is considered the minimum for a therapeutic lavage. At 200 cc's, you do have a reduction in the amount of protein, bradykinin, and IL-6. And somewhere around 300, and anything after 300, pretty much there's no more detectable protein, and you remove 99.9% of inflammatory mediators. So the answer on the test would be how much you have to irrigate, somewhere around 300 millimeters or more. In terms of joint space size, so the upper compartment can hold 1.2 ml, and the lower compartment is 0.9 ml. Now that is different from when we insufflate the joint. When we inject lidocaine, when we do any of these procedures, we inject lidocaine into the upper compartment. We do it both for anesthesia as well as to identify where the upper compartment is. And when you do insufflate it, you can actually insufflate somewhere between 2.5 and 3 cc's of local, and then you get that plunger rebound, and you get that sensation that you feel that the upper compartment is fully distended and full. So it's interesting that it normally houses somewhere like 1.2 ml, but we can I guess distend the capsule so that we can insufflate it enough with between 2.5 and 3 cc's of local anesthesia. All right, second procedure. Moving on to a high condylectomy. So a high condylectomy is indicated for condylar hyperplasia. As you can see in this picture, you have a elongated condylar head and neck. So if you also notice, this patient has an ipsilateral open bite due to the condylar hyperplasia. It can be diagnosed with bone scintigraphy, or you can use a technetium 99 scan if you're trying to look for active growth. Now, there is some discussion as to whether this should be treated during active growth or if you want to wait till it burns out and the growth has ceased. Now, different approaches, but the high condylectomy, this procedure is designed for treating an active growth. And the thought process is that when you do the high condylectomy and you remove between 3 and 5 millimeters of bone from the condylar head, that will disrupt the growth center. Right? We know the condylar head is what houses the growth center. So the high condylectomy arrests the excessive and disproportionate growth of the mandible by surgically removing the principal growth site. All right, so that's the high condylectomy. Again, you're removing between 3 and 5 millimeters from the condylar head. Moving on to the next procedure, condylotomy. This is different from condylectomy. This is condylotomy. Condylotomy is actually very similar to an IVRO. So this comes from the first observation that patients who sustain a condylar neck fracture, they tend to have no TMJ clicking or pain or dysfunction, very rarely at least. And so why don't we replicate that? So a condylotomy is a subcondylar osteotomy that mimics a subcondylar fracture. And the goal is to increase the joint space. So you can see, because we're displacing this condylar fracture, you're then increasing the joint space. And that should, in theory, unload the retrodiscal tissue, and that should relieve the pain and the mechanical interferences. So the thought process is, hey, look, when patients have a condylar fracture, their joint tends to heal very well because it's in a passive position, very similar to an IVRO. It's in a passive position, so the joint is finding where it anatomically wants to be, and therefore that's favorable because it unloads the joint. A couple of caveats when it comes to condylotomy. So we do detach the medial pterygoid, and we intentionally induce condylar sag. One thing that's interesting about a condylotomy, which is different from, I guess, a lot of the other procedures we're going to be talking today, is it's extra articular. So that's an important point, because there's only so many times that you could do a procedure, even as minimally invasive as arthrocentesis. Every time you operate on a joint, you induce trauma, right? Even like an arthrocentesis, when we inject a needle into the joint cavity, we are piercing through the capsule, and we are injuring the capsule to some extent. So even though we're trying to remove all the sources of the inflammation, we also introduce some inflammation just from the puncture site itself. So there is a limit to how much surgery you can do. So what's nice about a condylotomy is you're changing, by inducing a subcondylar fracture, you're unloading the joint, but you're not actually doing any surgery within the joint. So you can still do a second surgery. So that's a nice little aspect to a condylotomy. One of the downsides is, because it is a fracture, you have to put the patient in MMF, right? And this is very similar to an IVRO. How long do you need an MMF? Well, typically, if it's just a unilateral patient, some providers may do as little as 1 week. But if it's bilateral, you're going to err on the side more of 3 weeks. But it's somewhere between 1 and 3 weeks of MMF to allow the osteotomy or your induced fracture to heal. In terms of condylar sag, you're going to look at it from the inferior border, and you want somewhere between 3 or 4 millimeters of condylar sag, and then you know, if you see that amount of sag, you know you've increased the joint space by that much. Then they may ask you a question, how can you control the amount of condylar sag? The answer is by stripping the medial pterygoid. So the more you strip, the more condylar sag you induce. In terms of the technique, it's very similar to an IVRO. There is one important anatomic term or site to be familiar with. That would be the antilingula. So the antilingula is a bony prominence on the lateral aspect of the mandible. Now, it's not a great landmark, but they may ask you about it anyway. So clinically, I don't love it because it's not like it's very easy to find, and not every patient even has a very clear bony prominence. But it has been shown, Aziz and Zakari did a study that showed it does correlate. So the thought is the antilingula on the lateral aspect of the mandible does roughly correlate with the lingula on the medial aspect, because when we do this IVRO procedure, we're only really exposing the lateral aspect of the condyle. We're not seeing the medial side. So if we're not dissecting the medial, we're not going to directly see where the lingula is. We're not going to see where the nerve is. So we want to make sure we're posterior so that we avoid injury to the inferior alveolar. So the way we do it is we identify the antilingula and we go posterior to that. So that's just one anatomic reference to be familiar with. All right, moving on to the next category would be arthroplasty. Within arthroplasty, we have eminectomy, discopexy, and discectomy, or what's also called the meniscectomy. All right, they have different indications, so I want to make sure we keep them straight and we don't get confused. When it comes to eminectomy, eminectomy means to cut off or reduce the eminence. That is primarily for a recurrent dislocation, which is different from the other two things on this list, discopexy and discectomy. That's for internal derangement when the disc is damaged or when the disc is not damaged or it's just in the wrong position. So let's separate. All these, I guess, fall in the category of arthroplasty, but they have different indications. So once again, eminectomy is primarily for recurrent dislocation. That said, some people do, and this may sound confusing, so primarily for recurrent dislocation, but it can also help for internal derangement, and sometimes it's used for internal derangement. So the goal is to reduce the eminence. The reason why it works for recurrent dislocation is Not that it helps prevent it, but if the patient is going to dislocate, it then helps them reduce themselves quite easily. So let's think about what is a condylar dislocation. It's when the condyle translates too far forward and it comes all the way in front of the eminence, and you get an open lock. And sometimes patients present to the ED, maybe you're familiar with seeing patients like that. You have to push down and back to reduce the condylar head back into the glenoid fossa. And if patients have recurrent dislocation, there's various ways of treating it. You may be familiar with, you can inject PRP into the joint to induce fibrosis. That's one way. You could put the patient in MMF. But the most common and the most predictable way of treating them is with an eminectomy. So we shave down the eminence. That's, again, not to prevent them from translating forward, but just to help the patient self-reduce. So in the event of condylar hypermobility and dislocation, the condyle will slip back posteriorly back into the fossa, so it'll just be easier to reduce them. And there are different studies that talked about high slope versus low slope, but that's not basically every patient. Those slopes, I would throw them out. It's not important to know because every patient is different. There are patients with high slopes that don't dislocate ever. And so it really is patient specific, and I would throw out those numbers. Besides for eminectomy, like I said, is the most standard and common and the best approach, and I would say it has the best success. But you should be familiar with, for historical reasons, some of the other approaches. So the other approaches actually have a different goal in mind. They're not to help reduction, but they're to prevent dislocation in the first place. So when it comes to an L-shaped mini plate, you can see this plate was placed over here, and you can see on the pan it's placed here. The goal there is to prevent full translation of the condylar head. So the thought process here is if we could prevent the condylar head from translating too far forward, the patient will not be able to excessively open, and then therefore if they can't open too much, they can't dislocate. So that's one way of preventing them from dislocating. The problem with these mini plates, the reason why they fell out of favor is they tended to fracture, and once you get hardware failure, you had to do a second surgery just to remove the broken fractured plate. So it wasn't a great option. You also do have the LeClerc procedure, like we mentioned last time. This is also known as the LeClerc-Daughtry blocking procedure. Here you're inducing a zygomatic arch fracture and you're displacing the arch into the path of the condylar head. The same idea as before. You want to disturb the full translation of the condylar head. You want to block the condylar head from translating forward, and therefore you're preventing opening and preventing dislocation. Lastly, I do want to mention capsular plication. That means you're tightening the capsular tissue. And here, this is still aimed at right now, we haven't left talking about treating dislocation. The eminectomy was the standard way, but also you could do the mini plate, you could do the LeClerc, and you could do capsular plication. All different ways of treating recurrent dislocation. So here, you're removing a small little segment of the capsular tissue and you're tightening it. And if you're tightening the capsular tissue, that's going to indirectly tighten everything. And so if you tighten everything, then you're going to prevent, if you're tightening all this tissue back here, you're going to prevent this condylar head from translating too far forward, and hopefully you're going to prevent dislocation. Capsular plication is not very commonly used. It doesn't really work very well, but I just want you to be familiar with it. The goal is to tighten and limit the capsular laxity. So if this is tightened, then in theory you won't be able to translate too far forward. All right, now we're moving on, and you have to completely separate topic. Now we're no longer talking about dislocation. Now we're talking about anteriorly displaced discs, internal derangement. So what happens when the disc is too far forward? So your first option is discopexy. Discopexy is appropriate when the disc is healthy. So you wouldn't use this if the disc is perforated, obviously, but let's say the disc is structurally intact, has a healthy appearance, and it has adequate mobility. So then the disc can be salvaged. All it needs to be is it needs to be repositioned. So how do you reposition it? There's different techniques. The most conventional discopexy means you're suturing the disc. So conventional methods include repositioning the disc to the normal position and securing it to some stationary structure, namely the temporalis fascia or the retrodiscal tissue. So you're going to reposition the disc to some stationary structure to prevent it from being anteriorly displaced. The problem is it tends to recur because the retrodiscal tissue, or any tissue for that matter, will eventually loosen up and become lax and stretch, and then the disc will subsequently be displaced. And that's what we found when we did these conventional discopexy, that they may be in the short term, they may look like we reposition the disc, but they all relapse and they all have anterior displacement, internal derangement a year or two later. So then came a new approach, was the Mitek anchor, and this has been shown to be a little bit better. So studies show there's less relapse. And what's different about this is instead of suturing it to some tissue, which can then stretch, we're going to stabilize it to the bone. So this Mitek anchor is a 5mm titanium anchor that gets embedded into the lateral aspect of the condylar head. So you're going to drill it into the bone, and then you're going to suture it through the eyelet. You're going to run this 2-0 non-resorbable suture, and you're going to suture the disc. So you're suturing and you're tethering the disc to the bone. And this has been shown to have less recurrence because it has a better anchorage site. Finally, we get to discectomy, or also sometimes called meniscectomy. So in this case, it's no longer salvageable. So at the point where we reach discectomy is when we're dealing with a dysfunctional, a deformed disc that can no longer be salvaged. So just as a throwback, we talked about the Wilkes classification last time. If you remember, what was a Wilkes 5 was a perforated disc. So once you get to that point where the disc can no longer be salvaged, you're talking about removing the disc. And that in itself will help because you'll increase the joint space by removing the disc. And then the question is, what do you do after discectomy? So there's different ways of reconstructing the disc that you've now removed. Historically, and I'm mentioning this really, but it's fallen out of favor, is a silicone sheet. So you can interpose a silicone sheet, and usually it was put with some kind of tab so that you'd be able to subsequently pull it out. The thought process is, let's keep it in there for the first 3 months until the tissue fibroses, and then you pull out the silicone sheet. The problem is patients were having some foreign body reactions, and it also has very poor wear properties. So that fell out of favor, and then everything subsequently has not fallen out of favor. So these are all viable options. You could use auricular cartilage, so you could borrow cartilage from the ear. That has been shown to be effective, although it wasn't perfect. So there are concerns about the cartilage becoming fibrotic or fragmenting. You could also use a dermal or a fat graft. You could use a temporalis rotational flap, or you can simply just do nothing. And they all have various successes. So discectomy alone, meaning no reconstruction, showed about 86% success versus the temporalis flap, 91%, the auricular cartilage, 82%, and the dermal graft, 87%. So all of them are fairly successful, and the temporalis flap may be just a hair better than the rest. But technically, you could do discectomy alone has been shown to be perfectly fine as well. All right, and finally we're on to our last topic of TMJ reconstruction. So up until now we talked about minimally invasive. When all else has failed, we're looking at reconstruction, and there are various ways of doing it. Like I said before, you could do autogenous, so you could do a bone graft. You could do distraction osteogenesis, or you could do alloplastic reconstruction. And again, we're going to conclude with that because that's the workhorse of maybe modern day TMJ surgery. Indications, like we said before, this is when all else has failed, all the minimally invasive. So we're talking about very end stage arthritis. We're talking about ankylosis, a patient can't open, a very poor MIO, right? And ankylosis could be due to trauma or infection. Why trauma? It's the hemarthrosis. So anytime you induce blood, you have blood in the joint, hemarthrosis, you can then subsequently develop ankylotic or heterotopic bone and ankylotic, and you get a fibrotic mass, and therefore the patients can't open. So you have to resect the ankylosis. We did talk about that last time a little bit. And then, of course, there's congenital deformity. So this is more for kids that you're thinking about this, but hemifacial microsomia and Treacher-Collins. There are pathologies of the joint that may involve resection, and of course if you resect it, then you got to then subsequently think about reconstruction. So the most common neoplasm of the joint, this can definitely be a question. The most benign would be an osteochondroma. You can also have synovial chondromatosis. You have neoplasms that are of odontogenic origin, so they originate maybe in the ramus or in the body, but if they were just neglected and they extended and they grew for long enough, then of course they could reach the condylar head if you just let them grow long enough. And you also have idiopathic progressive condylar resorption. where the condyle just resorbs on its own, and then of course you need a reconstructive. So for any of these reasons, you're looking at total joint reconstruction. And like we said before, very end stage Wilkes, like a stage Wilkes 4 or 5, at that point you're considering reconstruction. When we say end-stage disease, we usually mean in terms of function. It's a very simple definition. The patient cannot function, they cannot chew, it hurts, they can't open. So very end-stage arthritic disease. And what are your options? So like we said before, you have 3. The first one will be autogenous bone graft. Autogenous bone graft, we're going to talk about it. It is primarily used for children. All right. Now there's different sources, so you can harvest the fibula, the coronoid, the ilium, the clavicle, but most common it is the costochondral graft. Now the fibula works. Let's say you're dealing a squamous cell and you're doing a hemimandibulectomy and you're removing half the mandible. So if you're going to reconstruct the body and the ramus with the fibula can also be used for the coronoid. It actually works quite well. You just leave it as a stump and then a neocondyle will form just naturally. So the fibula can work. But if you're just doing a small graft, then a costochondral graft would be the graft of choice, and that's for a few reasons. So number one, it has an ease of adaptation, similar size and dimension. Just look at it. It almost looks like a condylar head. Secondly, it has anatomic similarity because it has a cartilaginous cap. Now it has hyaline cartilage, and I guess to refresh everyone's memory, the disc is fibrocartilage, but we can't get too picky. So it has a cartilaginous cap. I guess that's that's pretty good aspect to it. And because it has a cartilaginous cap, it has a regenerative growth potential. And that's very key, and that's probably why we favor it when it comes to children. Because of course, if you're putting some kind of prosthetic device, that's not going to grow with the child, but if you're putting some kind of graft, and assuming the graft is successful and it takes, then this has the potential to grow with the child. I do want to mention that there was an article this month that did talk about alloplastic materials for children, and it could be in the future we'll get to that. But again, the board is dated, and when it comes to the board, the answer they're going to want for a child is autogenous costochondral graft. And this procedure dates all the way back to Gillies in 1920, so it has a long history. And here you can see a picture of what it looks like. Here's the graft and the fixation that you use. When it works quite beautifully because, like I said, it has a cartilaginous cap and it has a growth center, and it could grow with the child. So here's here you see a pathology that was resected, and then you see reconstructed, and then 8 months later you see a whole neocoronoid and neocondyle forming. And that's incredible when you do get the success, but the problem is it's unpredictable, and you don't always get that success, and there are some complications that can be experienced. So let's look at some of the numbers. So 60% you will get a graft take and good remodeling, which is great, and that's the most ideal circumstances. But unfortunately, the other 40% of the time, you can get partial or complete resorption. You could get overgrowth. So that does have, remember, it has a growth potential. It has cartilaginous cap. One thing that we try to limit is we try to make sure the cartilaginous cap is not greater than 3 millimeters. More than that, it tends to overgrow. So if it overgrows, now you're talking about something like condylar hyperplasia, where you're going to have to keep shaving it down and doing condylar shapes. So you don't want it to overgrow either, and you can also get reankylosis, right? Besides for pathology, a lot of times kids are treated for ankylosis. So you're going to resect the ankylosing mass, and then you're going to reconstruct it. Well, if they reankylose, well then I guess you're back to square one. So that would also be a very unfortunate complication. So the negative, like we said, is you have mixed results. It only works 60% of the time is acceptable, versus TMJ Concepts has a 95% acceptable rate. So TMJ Concepts is just much more predictable, and that's why it's the treatment of choice when it comes to adults, and costochondral graft is primarily only really for children. A couple other negatives to mention besides the results. So first off, it needs a second surgical site, and anytime you're doing another surgical site, the donor site, you could have increased morbidity. You could have pneumothorax 5% of the time, or infections. It is a longer surgery. It does require healing time, and that's going to be a problem in itself. So anytime you're doing this graft, in order to make sure the graft takes, you need rigid fixation, and you need 4 to 6 weeks of MMF. And that's going to be a problem for point number 6, because the longer the patient's in an MMF, well, then they can't do physical therapy. And we know the bedrock of TMJ reconstruction is early physiotherapy. So that's going to be a problem. And also then, the longer they're in MMF, the greater potential for developing heterotopic ossification and reankylosis. So again, these are all the negatives of costochondral graft. So it's not the treatment of choice. Second, we should talk about distraction osteogenesis. So distraction osteogenesis has a long history in the long bones, but it was only popularized in the head and neck region by McCarthy in '92. And the advantage of distraction is there is no graft, there is no donor site morbidity. You're just distracting a transport segment, and you're getting bony fill in between. So this is what it would look like. The green segment would be what you're resecting, so you cut this off. The blue segment is your transport segment, and then you're distracting it. And we should just review very quickly all these phases, because these are very important to know the different phases. So latency means after you do the surgery, you wait 3 to 7 days for the vascular supply to reestablish itself, and you don't distract it at all. Then you do the distraction phase, and there's different rates and rhythms of it. So you typically somewhere between a half a millimeter and a full millimeter every day, and then we divide that further. So let's say you're doing a full millimeter a day. Let's make the number simple. You may then divide that up into a quarter millimeter every 6 hours. So 4 times a day, you may do a quarter millimeter, so that in total you're doing a millimeter a day. Or you could do a slightly slower rate, and you could try to do half a millimeter a day, and you could break that up into a quarter millimeter in BID. But the goal is you're trying to distract it slowly and carefully, and you're trying to get bony film. And finally, you're going to do consolidation. So to make sure you don't get relapse, you're going to then just hold it. So after you're done distracting it, you're going to do a consolidation phase, typically 3 times as long as your distraction phase. And I just mentioned the ortho and the bite block, because you're going to have on the contralateral side, you're going to have an open bite. Okay. So that's distraction osteogenesis. And finally, we get into my favorite topic, which is alloplastic materials. And I'm going to you're welcome to skip this. This is not so high yield for the boards. I just find this very interesting. I love the history. Mercuri presents it if anyone wants to read it very nicely, all the history of this. And there's a really nice quote that he starts off with. He says, "Medicine, like all knowledge, has a past as well as a present and a future. The past is the indispensable soil out of which all improvement must grow." And so I think it's a really important starting point if we just familiar ourselves with the past, and that's how we appreciate where we got to today. So the first time where anyone did any kind of alloplastic material was Dr. Carnochan, and you can read all about him. He was kind of a cowboy, and he did some incredible surgery, and he was the first person all the way in 1840 that put a wood block between the raw surfaces of the mandible so he did gap arthroplasty, and he stuck a piece of wood in between, which is kind of crazy to think about it at the time, but his goal was to prevent re-ankylosis. That's followed up by Dr. Egers in 46, who put metal, he put tantalum foil, and that was also to prevent recurrence. Finally, Smith and Robinson, 1957, they had a fossa prosthesis that was kind of clever. So they designed a slot, and they would just slide this in, a slot prep. They would slide this in, and it had a rotational aspect. So I guess this is the first time it's starting to look more and more like a modern day prosthesis, because they were trying to account for that hinge movement. Finally, we get to the Christensen in 1963. He creates a fossa prosthesis made out of Italium. So in 63, he just did the top. You can see in this, sorry, my mouse. You can see over here, this is the fossa prosthesis. And then 2 years later, he actually made the first total joint. And we say total joint, what we mean by total, we're talking about 2 sides, right? Every condyle has both a glenoid fossa and a condylar head. And so if both of those are prosthetic, that's considered a total joint. So Christensen in 65 makes the first total joint. Initially, he was doing it out of polymethyl methacrylate. So the condylar head was polymethyl methacrylate, and this was Vitalium. That worked for a while, and then over time he noticed that the polymethyl methacrylate started to wear down, and he switched it to a metal on metal. And there is a modern day Christensen prosthesis, and believe it or not, the test will ask you sometimes materials, and this is an old question I saw. So the Christensen prosthesis is a chromium cobalt on chromium cobalt, or a metal on metal prosthesis, and that definitely is fair game. They can ask you, they love to ask you about weird stuff like that. Okay, some other designs, we're going to go through this more quickly. Over time, people kept trying to come up with the idea of how to make it fit better, and they came up with various different stocks, and the patient intra-op, you can choose which stock fit best. You're going to get to the infamous Kent prosthesis. So this was a total disaster. You guys have probably heard about this. This is the Proplast. This is the Teflon coated prosthesis. The goal there was we thought this would be perfect and it would have no wear and it would just slide well, but unfortunately it caused all these giant cell granulomatous foreign body reactions, and they all had to be removed, and this was discontinued. So that was quite a disaster. A couple of other variations in terms of how to fixate it. We tried to avoid using any kind of screws because the concern was maybe because of micromotion, those screws will loosen and hardware failure, so they tried to use polymethyl methacrylate cement. And there were some problems with that. And finally, you get to 1994, Mercuri and Wolford have Techmedica. And Techmedica is the predecessor of TMJ Concepts. So this is, I guess, this is the first model of what we currently use, and it was the first custom prosthesis. So here they're using the patient's own CT scan to fabricate a stereolithic model, and then they make the prosthesis on the model. So this will be a picture of modern day TMJ Concepts, and we're going to go through those materials because the materials are quite important. So they have a titanium mesh for the fossa prosthesis. And then for the fossa, they have ultra high molecular weight polyethylene. And then for the condylar prosthesis, you have an alloy of chromium, cobalt, and molybdenum. And we'll talk a little bit about all of those materials. It took a long time in coming until we realized that those were the best materials for all different reasons, which we'll talk about. And then the biggest competitor to the Techmedica was this Osteomed prosthesis, which is, I guess, the modern day Lorenz Biomet prosthesis. And Lorenz Biomet is very similar to TMJ Concepts. They use the chromium, cobalt, molybdenum. They use the ultra high molecular weight polyethylene. The only difference is they don't use the titanium mesh. So the fossa prosthesis is entirely made out of polyethylene. All right, so from all the history, we learned quite a bit of quite a few things from trial and error. So the first thing we realized is if you just did a single prosthesis, meaning you just put some metal either on the fossa or you put it on the condyle, you tended to get bone resorption. If you put bone up against metal, the bone would resorb, right? That kind of makes sense. And so the only solution was doing a total joint. You had to put a prosthetic on both so that you had prosthetic rubbing against prosthetic, not against bone. And then we also noticed that, and this was kind of a sacrifice, an accepted sacrifice, that anytime you do this condylectomy and you remove the condyle, you do have to strip the lateral pterygoid. And the lateral pterygoid is responsible for both protrusive and lateral excursion. And so that was a sacrifice. If it's only ipsilateral, you still had contralateral preserved, but if you did do bilateral, then we knew there was really no way of overcoming that. You were going to lose the lateral pterygoid attachment. Yes, I know there's some articles that talk about suturing it and trying to lasso it to the prosthesis, but I don't believe that works very well. Anyway, what we learned in terms of shape and fixation, so over time we tried to make it adapt better and fit better, and we tried to come up with various stocks, and you could pick out the best stock that closely resembled your patient's anatomy. The problem is, and this is a theoretical problem, studies haven't shown actually that it's worse. Studies have shown that stocks work just as well as custom, but at least in theory, I want to point out the one concern theoretically when it comes to stocks is if it doesn't have a very great stability, then one concern is over time there might be micromotion, and you can get hardware failure. So we know if your condyle is just functioning a million times and it keeps hitting your fossa prosthesis, if the adaptation is not perfect, then the screws can loosen over time and then the hardware can fail, and that may lead to a decreased longevity. And so we did try the polymethyl methacrylate cement to try to avoid having to use screws, but the problem with the cement is it required an absolutely dry field, which was impossible to do surgically, and also there was a concern about just heating because the cement would heat and injure the tissue nearby. And finally, we got to the solution of custom-made, like TMJ Concepts, and that was kind of the perfect solution, and to this day, TMJ Concepts has like 75% of the market share. So pretty popular. In terms of wear and in terms of materials, we did learn quite a bit of things in terms of wear rate, in terms of gliding, surface pressure, and the geometry. So the Ken prosthesis was an example of something that did not work well. That was the Proplast and Teflon. The Christensen prosthesis, so they initially had the polymethyl methacrylate, but they noticed they did test. After about 10 million cycles, you lost about 1 millimeter of height, and that was significant because at that correlated to about after 13 years of function, this prosthesis would no longer work. And the best combination of alloy we found was chromium, cobalt, molybdenum, and that was found to have the best combination of strength, polishability, biocompatibility, excellent wear, and it would slide really nicely against this ultra high molecular weight polyethylene. So that became the gold standard. How long does this Techmedica work, or the TMJ concepts, how long does it work? Well, we don't know quite how long, but we do know, based on the first patients that Wolford and Mercuri worked on 25 years ago, all 25 of them, it's very impressive, all 25 of them are still functioning well. There were no failures. So the answer is we know it will last for at least 25 years. And in terms of the future, it's quite possible we'll have some kind of regenerative potential in tissue engineering, but we're not there yet. Now, as a bonus, I'm just going to take you through a surgery really quickly. The test will ask maybe some of this, so you're going to be doing your virtually. You plan for your condylectomy, so you're going to remove the condylar head and the neck. And how much clearance do you need? Typically, the answer is somewhere around 2 centimeters, measured from the glenoid fossa to the ramus. You can also hear a measurement, maybe the newer engineers will use this measure, from the eminence. You may want 13 millimeters of clearance. So you plan your resection, and they're going to give you a stereolithic model, and they're going to custom made the joint specific to this patient, and then they can give you a cutting guide. So over here, don't get overly concerned with this L shape. This is not standard. I usually just do a slant, a straight line from the posterior ramus to the sigmoid notch, but in this case I did an L. I did it for clearance purposes, and I didn't want to remove the coronoid. But of course, you could also just go all the way across and remove the coronoid if you're concerned about the coronoid. And even in this patient, does have a little bit of a high of a coronoid, so that was perfectly reasonable. But anyway, don't get concerned about that. The surgery itself involves 2 incisions, so you're going to be doing a Risdon or a retromandibular incision to expose the ramus. That's for your condylar prosthesis, and over here is a diagram just showing the Hayes-Martin maneuver, so you can protect the marginal mandibular nerve. You're going to do a preauricular incision. Again, I'm not overly concerned with incision for the sake of the boards. I do want you to know the layers. That could definitely be a question, so I'm going to just quickly review it, and then we'll talk about it more in the next episode. So the layers, the first fascia you're going to encounter is the temporoparietal fascia, and then deep to the temporal parietal fascia, that's where you find the nerve. So the temporal branch of the facial nerve is deep to the temporal parietal fascia, and then deep to that layer is the temporalis fascia. So again, temporal parietal fascia, then nerve, then temporalis fascia. That's important, just knowing that sequence of those layers. So you're going to do a preauricular or an endoral incision. Like I said, 2 incisions, Risdon, and then preauricular. You do have to know this is an important number. This green line, 8 millimeters to 35 millimeters. This comes from a famous Al-Qaeda and Brownlee. I don't want to rush through it. You should know this, and if you don't know it, check out my journal club where we review this article. It's really a classic article that everyone should be very familiar with. All right, so here's exposing the ramus and the angle, and that's for our condylar prosthesis. And then you're going to put on your guide, our cutting guide. I'm zoomed in. I'm going to cut with my reciprocating saw against that. Then from your preauricular incision, you're going to expose your arch, and then you're going to get into the superior joint cavity. Then you're going to remove the lateral capsule, and you're going to find the joint. I do want to talk about all the ligaments. The test, sometimes they do ask about ligaments, so you have to know there's the lateral ligament. Now, all the names are actually quite easy, so that's on the lateral aspect. Here's the sphenomandibular ligament coming from the sphenoid bone. And finally, from the styloid process, you got the stylomandibular ligament. So all these ligaments are to prevent excessive movement of the condylar head. And even the capsule itself is a ligament. It's important, even though we think of it as a capsule, it's important to remind ourselves it is a ligament. This diagram here is just to remind us that the lateral pterygoid attaches to the condylar head, and that's for protrusion and lateral excursion. All right, so here we're getting into we're removing this white thing over here. This is the disc, so you have to remove the disc when you do the surgery. Now we're isolating the condylar head, and you're going to use a reciprocating saw. But actually, more recently, I stopped using reciprocating saw. I started using a sonopet. I highly recommend it if you're doing this procedure. It's a little bit safer from the artery. Now, this is a question they're going to ask you: what artery are you concerned with? So when you're doing your condylectomy, we talked about this in the last episode, you have to be concerned about the IMAX, the internal maxillary artery, which is 20 millimeters from the condylar head. And so one way of avoiding injuring if you were to cut all in one cut all the way down against your surgical guide, you could probably be around 20 millimeters away from your condylar head, and that's approximately where the IMAX is. So one way we avoid that, besides for using a sonopet, which I also recommend, is we cut it in pieces. So you first just cut off the condylar head, and then you push up. And by pushing up on the ramus and distracting it up, you're actually pushing the bone away from the IMAX, and that would be a little bit safer. And then here you're just seeing the prosthesis seated, both the fossa prosthesis and the condylar prosthesis. And that's it for this talk. Do join me in the next episode. I want to talk a little bit about I have old questions, and we're going to go through the questions, and hopefully between the two videos where we talked about the anatomy, physiology, and some of the procedures, along with the questions, we'll fill in all the gaps, and hopefully you get a really good sense of TMJ, and then we'll move on to infections, which will be next. And I'll see you guys in the next episode.